Thanks for the introduction. I'm actually a medical student from UFT, so still not a doctor, but maybe one day. So I'm just here to present the results of our comparison of the Uniportal versus Multiportal video-assisted thorascopic surgery in the treatment of lung cancer. This was a study conducted out of Credit Valley Hospital, which is a Trillium Health Partners out of Mississauga, Ontario. My conflict of interest disclosure was prior to getting into medical school. I worked in sales and marketing roles in the pharmaceutical industry. So the background to our study, in 2014, Rocco and colleagues described VATS for minor thoracic and pulmonary procedures. In 2010, the first uniportal VATS lobectomy was described by Gonzalez and colleagues. Last year, there was a review paper that was published. It was a meta-analysis of about 8 observational retrospective studies with a patient population of about 1,800 patients that compared uniportal versus multiportal VATS lobectomy for the treatment of lung cancer. It showed that uniportal VATS conferred an advantage in the reduction of hospital stays, duration of chest tube drainage, and the overall incidence of morbidities for patients. However, the thoracic surgery group out of Credit Valley felt that there was a limitation to this review paper that was published. Primarily, VATS cases that were converted to thoracotomies were excluded from the analysis when they compared uniportal versus multiportal patients. As well, initial uniportal cases that were converted to thoracotomies were excluded from the analysis in this review paper. And finally, the reported length of stay was significantly higher than what is generally being reported by the Society of Thoracic Surgeons' General Thoracic Surgery database. Therefore, we felt that we needed a study that would identify value propositions, if any, that uniportal VATS conferred versus multiportal VATS in the treatment of resectable lung cancer. This was a retrospective observational single-center study. It was performed by a single surgeon. They were performed over 50 months, and we used intervention codes to identify patients that underwent any VATS procedure. Our inclusion criteria was either pre or post-operative proven diagnoses of primary or secondary lung cancer, and they must have either underwent a VATS lobectomy, a segmentectomy, or a retrosection. We excluded VATS pneumonectomies because we didn't have enough patients in both groups to conduct an analysis. So we identified about 185 patients that underwent this procedure over a 50-month period, and we included 65 in our uniportal VATS group and about 63 in our multiportal VATS group. When we look at the initial patient demographics, both groups were well matched for mean age, gender, mean BMI, FEV1 predicted, and mean DLCO. So there was no difference. When we look at patient-reported comorbidities, for the vast majority of cases, there was no imbalance between both groups. However, when it came to patient-reported COPD diagnosis, it appeared that the multiportal group had about a 50% less prevalence of COPD versus the uniportal group. However, when we look at parameters such as FEV1 predicted, and DLCO, there were no differences whatsoever. So we speculated that this difference was just due to patient underreporting. When we look at things such as current smoker status, smoking history, and mean average pack year, there was no difference between both groups. Moving on, when we looked at the histological tumors that were resected, the vast majority of tumors that were resected were adenocarcinomas, and the other tumors that were resected is listed in this table, but again, there was no difference in the types of tumors or pathologies that were resected between both groups. When we look at staging, the most frequent staging kind of tumor removed was stage 1B. There were 2 cases of stage 4 cancers, but they were found to have metastatic disease shortly after surgery. And once again, there is no difference in between the staging of the cancers removed from both patients. When we look at tumor size, there was no difference. And when we look at the tumor location, most of them were removed from the left upper lobe. But again, there was no difference between both groups. So the reason we went through that initial analysis was to just make sure that since this is a retrospective study, that both groups are as well matched as possible before we start looking into the perioperative and post-operative variables. So when we look at the kind of procedure that was mostly performed, the one that was mostly performed was lobectomies. When we look at decortication, there was no difference between both groups. When we look at the median duration of the operation, it was about 180 minutes for both groups. This involved bronchoscopy and invasive mediastinal removal of the tumor for pathology. And when we look at the median number of cartridges, there's no differences between both groups. Therefore, this shows us that uniportal VATS doesn't confer increased resource utilization when we compare it to multiportal VATS. And when we look at the conversions to thoracotomies, again, there's no differences between both groups. The vast majority of the conversions occurred due to difficult dissections. There was one conversion that occurred due to a bleed from a staple line, and that was only in the uniportal group. When we look at median lymph node, removed median lymph nodes involved and the number of positive margins, again, both groups are very equal and there's no differences. This indicates to us that uniportal VATS does not compromise oncological treatment principles and is not harmful to the patients. When we look at the blood transfusions required and median blood loss from uniportal VATS versus multiportal VATS, again, there is no difference, indicating that this kind of surgical procedure is safe overall. Now, when we looked at the median post-operative hospital stay, we saw that there was a 1-day reduction in the uniportal group versus the multiportal group. When we also looked at the median duration of chest tube drainage, there was likewise a 1-day reduction in the uniportal group versus the multiportal group. When we looked at admissions to critical care, there was no difference. When we looked at further procedure requirement, there was no difference. And when we looked at the complication rates, there was about a 44% reduction in complications in the uniportal group versus the multiportal group. So when we investigated what were these post-operative complications, the most frequent post-operative complications that we can see is prolonged air leak. In our study, prolonged air leak was defined as air leak 3 days post-operatively requiring discharge of the Heimlich valve. This is different from the traditional definition, which is 7 days post-surgery for a thoracotomy. The group felt that since uniportal VATS was a minimally invasive surgery, there should be an introduction of a paradigm change definition for prolonged air leak. So that was the most frequent post-operative complication that contributed to the statistical significance. And the remaining post-operative complications you can see there between the uniportal versus multiportal group. When we look at median 24-hour patient-controlled analgesia use and the 24-hour visual analog scale and the median duration of patient-controlled analgesia use, there was no differences between both groups. This kind of came surprising to us because anybody who's looked into this in the literature will see that other studies reported that there was better pain control when patients underwent uniportal VATS versus a multiportal VATS. So this was a little bit surprising to us to see that there was no difference in this field. When we look at inpatient mortality, there was no difference. There was one patient that died in the multiportal group. This was due to respiratory failure. And then when we looked at the 90-day mortality, there was one patient that died in the uniportal group, but this is due to metastases to the brain. Therefore, our study appears to show that patients that underwent uniportal VATS for the treatment of lung cancer benefited from about a 33% reduction in median hospital stay. They also appear to have benefited from a 33% reduction in duration of chest tube drainage and about a 44% reduction in post-operative complications. We think that these differences are quite significant, and it shows that uniportal VATS is a safe procedure. It doesn't compromise oncological treatment principle, and it appears to reduce resource utilization when it comes to the treatment of lung cancer. And of course, we'll need multi-center prospective studies rather than retrospective studies to corroborate our findings. And that's the conclusion of my study.
Very well done. That was nicely presented as well. Does anyone have questions?
That was an excellent presentation, and very excellent study. I have a question. Do you look at the conversions? Were there any in the multiportals where they start out as uniportal? Was there any conversion instead of to open thoracotomy, but from uni to multi?
So that did happen. The way this study was performed, Dr. Bizzati, for the first 2 years of the study, just exclusively performed multiportal surgeries. And then when he felt comfortable enough, he just switched exclusively to uniportal VATS. And if there was any conversion performed, he would go into a thoracotomy if it was necessary. So there was no uniportal to multiportal conversion during our study.
And one other question, because there's a temporal difference in your cohorts, was anything else that changed during that period of time? Was there an introduction of enhanced recovery pathways in order to explain the shorter length of stay?
The only thing that was changed that came up to mind was the patient-controlled analgesia. For the first 2 years of the study, the hospital was administering morphine more frequently. Then they switched to a lower dose of opioids, which was hydromorphone. Now, could this have inadvertently contributed to a shorter stay? I'm not too sure.
Dr. French?
Thank you. Nice presentation. I have two questions. One with the chest tubes. Was there a chest tube protocol or how were the chest tubes managed? My thought being that your shorter length of stay is probably related to the shorter length of chest tube drain. And so I was wondering if that was standardized or not. And the second question is like, going to the future, any thoughts on how we might look at chronic pain after multiport versus uniport?
So to answer your question, to the best of my knowledge in my discussions with Dr. Bizzati, if the patient felt well enough to be discharged with a Heimlich valve and they didn't have any comorbidities, they were discharged, there was no standard protocol. So perhaps there were variations in the management of both groups over the 50-month period that could have maybe biased it, but to my knowledge, we did have a standard discharge procedure. If they could leave 2 or 3 days post-operatively, they were discharged aggressively. And regarding the monitoring the chronic pain, it would be, we don't have a protocol. The thought process where if this study was to become bigger, to have something where you can check in with patients 1 month after surgery, 6 months after surgery, and using a validated pain scale questionnaire. But given that this was a community hospital with very limited resources, we weren't able to explore that.
Yes.
So, these cases, were they the first uniportal cases done included in this analysis, or was there, do you think, a selection bias in the first cases that were done?
I don't think there was a selection bias, only because for the first 2 years, Dr. Bizzati performed multiportal VATS exclusively, and then when he felt comfortable, he just made the switch to uniportal VATS and never reverted back to multiportal VATS. So because there was a 2-year period exclusively multiportal VATS and a 2-year period that was exclusively uniportal VATS, it limited the selection bias, in my opinion. But I don't have any stats to kind of prove that statement.
So these 60 cases or so would represent his learning curve, given his first 60.
Yeah. And so we saw that with the surgeon learning curve. Even when the surgeon switched surgical techniques, it did not increase resource utilization or place patients at greater harm.
Just a quick poll of the audience, how many people are performing uniportal lobectomies in their practice?
We have one surgeon.
Alan, can you comment on this?
Yeah, that's a very good study, great presentation, very comprehensive data. The only thing is we're seeing a lot of emerging papers like this in the journals that we're editors for. When you have the key outcome measures being chest strain duration, length of stay, I think the point was made just now, it's especially in retrospective study, you need to define what your criteria are for drain removal and for length of stay, because there's a chance of bias in that. The other thing about your pain, again, you need to define your pain protocols. You mentioned just now the PCA management might be a bit different. Always in any pain study, it's a confounding factor if you don't control for that. And that might account for why you didn't find a difference. Maybe, I don't know. There's one last comment though. You mentioned right at the start in your introduction, the length of stay, 6 days compared to 4 days. Most of the papers reviewed in the meta-analyses, most of them came from Asia.
Yes.
And we have completely different rules for discharging patients, and that will account for why the length of stay is a difference. For example, you discharge your patients home on Heimlich valves. In Asia, that does not happen. and that accounts for longer stays.
Yeah, thank you, that's a very good
Yeah.
point.
Very good. So nicely done. Thank you very much. We'll move on to the next talk. Also,